All. This is Mobeen Sayed from Drbeen.com. Welcome to one more show. So today we have with us someone who has been with us for a long time. We have Dr. Z with us. We have Dr. Zara Ashikyan with us. Dr. Ashikyan, welcome.
Thank you so much for having me. Very excited to be here.
Thank you. So a quick introduction to Dr. Zara Ashikyan, and then we would start having a discussion. The topic today is post-traumatic stress disorder, so PTSD. So let's very quickly see who Dr. Zara is. So Zara Ashikyan, she's a Ph.D. QME, is a clinical psychologist with expertise in forensic and neuro psychology. She completed her undergraduate degree at UCLA in experimental psychology and her PhD degree in clinical psychology at California School of Professional Psychology. She then also completed her internship and post-doctoral fellowship at UCLA. She is the founder and clinical director of Western Pacific Psychological Network, a multi-specialty mental health clinic. He's also a member of the board of directors of Glendale Memorial Hospital Foundation. For the past 14 years, Dr. Ashikyan has been conducting evaluations for private, court, and organizational purposes, qualified and agreed medical evaluations, as well as assessments for law enforcement and first responders related to fitness for duty, trauma, and risk assessment. Dr. Ashikyan has notable experience working with athletes related to post-injury rehabilitation and performance issues. She also has vast experience with cognitive and neuropsychological assessments for adults and conducts FAA evaluations for pilots and air traffic controllers. So that is the rock star that we have with us today. So once again, Dr. Ashikyan, welcome. Please tell us a little bit about yourself, your day-to-day activities, and how does your work go?
Sure. Thank you again for having me. I'm very excited to be here as a cool bean myself, and having heard so many of your shows and having seen so many of the great presenters, I've benefited greatly, as I'm sure all your audience has. And so day to day, I have both administrative duties at WPPN as well as clinical duties. I enjoy my time with patients, but I also enjoy the administrative work as well. And then, of course, when I can catch a live presentation on your channel, it's quite a treat. So that's sort of my day-to-day activities at work. Recently, of course, with COVID, we've also had either patients who are dealing with post-COVID symptoms, whether it's the actual long COVID symptoms, or the stress, the just purely psychological stress and the trauma of having survived such a horrendous illness. So that's about it.
Got it. Thank you very much. And just a quick note, cool beans here, viewers here, I want to make sure that you can look at this disclaimer. Here is a disclaimer. This is a sensitive topic. So please make sure that you read this disclaimer. It is here at the bottom of the screen as well. Dr. Ashikyan, any guidance for the viewers, for the listeners?
Yes, absolutely. Thank you for reminding me about that very important point. It is a very sensitive topic, and most people, either themselves or a loved one, has gone through some kind of a trauma in their lives. And it can be very triggering, emotionally distressful to even hear a topic being discussed in educational or informational manner. So I do want to caution anyone who thinks they may need to listen to this at a different time or possibly skip this one altogether. I think that would be very good. Listen to what your sort of body wants and what your brain wants, and trust that it's the right thing to do. So I want to encourage you to do that. And otherwise, if you want to join us, just know that it may bring up some unpleasant feelings and so forth. And again, you can click off and check back in when the video is up after live.
Got it. Thank you very much. And once again, for the audience here, This is not a medical advice. There is no patient-doctor relationship here. This is more of an educational and informational session. So please make sure that you treat it like that. And if you cannot, then please don't watch it. All right, so let's start our discussion. So Zara, what is trauma? So before we go to the post-trauma syndrome, what is trauma?
Sure. It's great to define it, obviously, to have the actual sort of shared definition of trauma. Trauma is a very distressing and very difficult experience that an individual has. Trauma, obviously, you can sort of already sense, is a very subjective experience. So it is not measurable and is not experienced the same way by every single person. So it's important to honor that if someone says this was very traumatic for me, that we don't add our own definition of what a trauma is and say, well, it doesn't sound like it was that bad. So trauma is a very subjective experience, but most of the time it is a very distressing and emotionally difficult experience to go through.
Got it. And once again, before we move towards PTSD, just from a general life nowadays point of view, for last 18 months, the pandemic, the lockdowns, the livelihoods, people, one set of beliefs, another set of beliefs, agreements, disagreements, scares, fears, can they all contribute to the trauma? Can they create trauma? Or can they exaggerate existing trauma? What is the role of all of this lifestyle at this time?
Absolutely. They can and they have. I think they have indeed caused significant trauma, whether it's through the observation of loved ones going through loss of a job, whether significant changes to their lifestyle and ability to continue providing for their families, whether it was the riots and a lot of the protests that we experienced last year, and a lot of protests still ongoing throughout the world for various different reasons. So yes, absolutely. The last year and a half has been quite traumatizing for some individuals. And I think we cannot all agree, rightly so, depending on what our exposure has been to the trauma.
Got it. Got it. Thank you very much. So then let's go to the topic, the PTSD. What is PTSD?
PTSD is post-traumatic stress disorder, and it's a psychiatric condition that requires, as you know, various criteria to be met. And to a certain degree, when you hear the criteria, you kind of start to think, well, this is a normal reaction to a trauma, until it gets to what makes it a disorder. And so let's go through those criteria very briefly. So the first and very important criteria that must be met is that there has to be a traumatic event. The traumatic event could be experienced by the individual, or it could be witnessed by the individual, or it could be someone close to them that went through a horrible experience, and then which triggered a fear for the individual's safety. So I would imagine a mother hearing that their teenage son was in a car accident and had significant physical injuries and so forth can be very traumatizing, even if the mother is in a complete different state and not at all physically proximal at all to the trauma itself. Similarly, it could also be individuals in the first responders, as well as counselors who experience secondary trauma through hearing of or exposure to traumatic events and incidents. For example, this could be any one of the law enforcement officers that I have personally assessed or treated who were either exposed to post-crime or post-accident scenes or post-accident or crime pictures. This could also extend to obviously lawyers and paralegals. Again, anyone who has a secondary exposure to trauma. So that's the first criteria that must be met. The second criteria is the experience of intrusive thoughts or images or memories. And again, you're thinking, of course, after a horrible event that you experience, you're going to have thoughts about it, or you're going to keep remembering it, or possibly see images of it or flashbacks of it, and so forth. So again, very normal response to a very abnormal event. Okay, so then, and by abnormal, I mean outside of the normal experience. And then, of course, there are the third criteria, which are avoidance. If you're constantly being reminded of thoughts and images, you're going to avoid reminders. And so avoidance behaviors come next, and they can be either inside the person, meaning you're trying to avoid talking about it, avoid thinking about it, or it could be avoiding the actual physical experience. If you had an accident on a particular freeway, you may avoid taking that freeway. Again, this is very common. There was a school shooting near where we provide services. So we saw some of the first responders after the event, and some of them went out of their way to make sure that they were not driving by the school for a significant amount of time, to make sure that they were not being exposed to scenes of the school, which would naturally bring up memories and thoughts and images of what they had experienced. So that's the third criteria. I'm going to try to keep my numbers straight. The fourth criteria is a change in mood and cognitions. So this could be cognitive distortions. So blaming yourself, for example, for an event or a trauma. It could be feeling, having negative emotions. It could be not remembering certain parts of the trauma. This is sometimes common with patients who experience what we believe to be dissociative amnesia. This is during the event, as a way to protect the individual, the brain tends to not focus on the horrors of the trauma, and therefore sort of like checks out of sort of awareness, and therefore memories aren't made as a result. So this is very different than someone not remembering certain parts of trauma because of a head injury, or someone forgetting certain aspects of trauma because of substance use or drug abuse. So it's a different kind of memory issues. And you'll hear people saying, like, I don't remember if it was, you know, if I hit them and then they hit me, or, you know, some certain aspect of the trauma itself. And this is very normal. And sometimes those memories return and sometimes they don't. There's also a significant, marked significant change in a person's response. We call this arousal, whether it's emotional or cognitive arousal. So you'll hear people say, I'm so irritable after a trauma. I had a patient who, and his family attested to this as well, that he was very calm, peaceful, all loving, all accepting. Literally, some people had never even seen him become upset ever in their entire lives. And he had become so frustrated and irritable that he once said, I'm getting angry at the red light at the intersection. So just a huge change in how someone responds to stimuli. This is also very prevalent with hypervigilance or hyperarousal. You see this with individuals who jump with a loud noise, or experience a huge response to a very benign sort of stimuli. And then, of course, again, if you've been following along with the criterion, so far you're going, this sounds all normal. Like, these are normal experiences to a horrific experience, until you get to things like, these symptoms are so severe and so debilitating that, first of all, they've been going on for more than a month. So there's a duration to how long the symptoms have lasted. And also, they are disturbing some or all functions or areas of an individual's life. So this could be significant difficulties in school, occupation, family, or all of the above, or social functioning. There's also sometimes as a way to self-medicate or self-soothe. Sometimes individuals start to also use substances with PTSD, but not always, obviously. And then there is so none of these symptoms could be as a result of substance use. So you definitely want to make sure that nothing else is responsible for any of these symptoms. Nightmares are also related to PTSD, and they don't generally need to be repetition of the trauma itself, but themes of either being harmed or chased. So the individual is still experiencing trauma in their dreams. And then, as I mentioned, the individual has to have been experiencing these for a month or more. And there's also a delayed onset. So it's very possible that someone doesn't go on to develop this until 6 months later or up to 6 months later. And we classify that as delayed onset PTSD. So that's PTSD.
Got it. Thank you very much. And while you were speaking about the PTSD, I was actually thinking the same thing that you said as well, that sometimes you will think that this is normal.
This
so
is
my question, right?
Yes.
These are normal experiences as well. So that is what I wanted to ask you, that these are normal experiences as well. But then it becomes a disease as well when there is duration attached to it, and when there are, so the question then, what is the recourse, what is the solution? How does somebody identify that I may have PTSD and I need to seek help? How does that process unfold for a person who may be going through it? Do we know if so let's say if I'm going through it, do I know that I'm going through this? Or what is the thinking process there?
Right. So it is likely to be as different as we all are, right? When you think about it, an individual may recognize the issue right away. Sometimes people don't wait until the issue becomes problematic in all of the areas of their life. So as you mentioned, these are all very normal experiences. In fact, when patients come in, what has happened is that they've been feeling bad, and then they've been feeling bad about feeling bad. And that is the biggest issue, that they have now sort of pathologized what I consider to be a normal response to a very abnormal event or incident. And so now when I say a normal response, I want to make sure that it's very clear that it's not a desired response. So it is normal in the context of what's happened. So if you remove the traumatic event and someone is experiencing these symptoms, that would be problematic, right? So given what this horrible event, their symptoms are, in my opinion, are considered a normal response to the trauma, because especially if you know how the brain works, and we'll get to talk about that hopefully later as to how this is evolutionarily set up as a protective method to our brain to help us after a traumatic incident. And so what you mentioned is, how do they come to you? So they come to us either by recognizing that they have experienced a significant traumatic incident that's causing them nightmares, so it's impacting their sleep. Generally speaking, it's something that is causing them a problem. And it's causing them enough of a problem, they've become uncomfortable enough to seek help, right? And the uncomfortable enough is different for all of us, right? We all have our tolerance level. So some people might seek help after not sleeping for 3 days in a row, others 3 months in a row. So generally speaking, patients come to us from different sort of time frames as to when the trauma was. Obviously, with any other illness or issue, the earlier someone seeks treatment, the better the treatment outcome. Of course, this is not to say that if they seek the treatment much later, they just have no hope. That is absolutely not the case. It's just that with any illness, I think we can safely close our eyes, open any page in the ICD-10, and any illness that we land on or any issue that we land on will always say early treatment or prevention is best method of treatment. So that would be my response to that in terms of if anyone does have it and they recognize it early, seeking treatment is helpful. But most of the time, it has become uncomfortable enough for them to make that step. Sometimes patients are referred by their family members. Sometimes they're referred by their primary care doctors. Sometimes their employers notice that, oh, you're not going to this area, or you're driving twice as long to not sort of pass by a particular area. Is everything okay? And so forth. So hopefully we'll all have people in our lives that recognize our need to seek treatment.
Got it. Thank you very much for that. I have two more questions before we move towards how do we start managing this. The two, or what is the normal management approach? But the two questions are the following. Number one, can PTSD be caused by the events that are decades away and they keep lingering, the syndrome continues? Let's say, is it possible childhood trauma continues to reflect when somebody is 30, 40, 50, 60, or is it always closely associated with the events?
Excellent. Yes, excellent question. So obviously both, and that's such a great question because we see this so much with law enforcement personnel or firefighters or EMTs whose job it is to be there at our worst days, right? So I obviously treat and evaluate many of these individuals. So my utmost respect and just high regards for anyone in these roles. And they're constantly throughout their life experience. In fact, their first day might be one of the worst traumas they'll ever experience, but they go on to work for many, many more years, sometimes several decades before they retire. And yes, absolutely, they can go on for years without getting any treatment and so forth. And this is one of the mysteries of the brain, where there's this protective layer almost that builds, especially for people who have to continue doing this traumatic work while they are still functioning perfectly well in all areas of their lives. They are still dealing with it, but they're able to manage and cope with the symptoms. And they eventually get less and less loud. The volume sort of goes down on those hyperarousals or in flashbacks or nightmares, and they're able to continue working. But sometimes I've noticed that when they retire or they experience one other event or an incident, and it doesn't have to be the worst thing they've ever experienced, but it sort of opens the gate to all the rest of the traumas that they've experienced. And they'll start to have symptoms related to events 10, 20, 30 years ago. So that is a very interesting question that you asked, because it's so relevant and very rarely talked about or discussed or managed.
Got it. Thank you very much. So one more question, and that is the brain, the chemicals and the brain structures and the functions and our evolution or the build. What is the role of brain in all of this? what is their limbic system involved in this? What is causing it? I mean, yes, there is a traumatic event and there is a response of ours. What are the structures involved? If you can give us a brief overview of that.
Of course, yes. And it is several structures become involved at various different times, either during the trauma or after the trauma. But it's essentially the fight or flight response. So basically the fear center of our brain, which is the primitive sort of area of our brain, where we have the adrenaline going during the event to sort of help us either fight or flight any of the traumas that we're experiencing, if it's a physical one, especially. And of course, the later response is considered a sort of a shift in how that works. So it seems that once the fight or flight response is sort of triggered with the trauma, for some people, the sensitivity changes. So, for example, I tend to look at anxiety similar to a smoke detector in our brain. And the smoke detectors, as you know, are set at different levels of intensity. For example, if you have a bad cook in the kitchen, you can easily set off the smoke alarm, but there's not exactly fire. There's just a lot of smoke. And then, of course, for some smoke alarms, it is set so sort of lazy or not very strong, where the half of the house might be on fire before the smoke alarm goes off, right? So, and we all know people who have various different anxiety responses, right? People who have anxiety to very minute and minor issues, and people who become very, very anxious only at like very severe instances. So, and it seems that sort of scale becomes unbalanced with PTSD, and people start to have more of a feared response a lot quicker and assume that it's fire and assume that it's very, very bad, as opposed to sort of thinking, well, it might be fire, it might be someone burning food in the kitchen, and it might be nothing at all, right? A very sensitive alarm. But for some reason, after trauma, that's triggered and it becomes significantly more high-strung. And this could be compared to also a car alarm, where some car alarms are triggered very easily and some not, and then there's a healthy middle ground. And after a trauma, it seems that that scale is off balance. So to answer the question regarding the brain, it's primarily the fear, the fight or flight sort of response, the sympathetic nervous system that's involved. And then, of course, with the limbic system, the emotionality and so forth, but also the hippocampus, right? Because of our memories and so forth. And then our dreams. Then it becomes with the avoidance, your cognitive or planning, the prefrontal cortex, and so on. So I would say a lot of it is involved in trauma.
Got it. So this is a complex picture within the brain that develops. So I wanted to go to management or the way this is approached, but I have another question that came to my mind while you were talking about this. So this scale that somebody may respond or become traumatized with an event that somebody else might not be. And of course, there is a relationship to that event and the people involved in the event that is on one side. Is this a bad thing if somebody becomes traumatized with lesser severe events versus somebody who continues on with maybe more stronger stimuli and still not be that traumatized? Is there a judgment there, or this is just how humans are?
Well, no, exactly. Thank you for clarifying. Not at all sort of good or bad or any kind of a judgment, but rather different. And I think that we are all aware of how different we are, and our responses to trauma are all very different, because all of us assign different meanings to the trauma. And we are sort of sliding into management when we start talking about discovering the meaning that we attach to the things that happen to us, right? Because when you think about the brain doesn't select to respond like this to just bad stimuli, right? Because we've been talking about terrible things and how the brain reacts terribly to certain things, but the brain reacts almost the same way to abnormal but very good events. And again, that's why I made the clarification about when I say abnormal, I mean outside of the norm, right? And so outside of the norm could also be, for example, your wedding day or when your kids were born. These were magnificently happy days, I'm assuming. And afterwards, perhaps for weeks or even months, you found yourself with images in your mind from that wonderful day. You experienced emotional stimuli as if that was actually happening again, right? You experienced joy. You probably were smiling, even though there was nothing in your actual environment that was that required that response. But again, we don't ever mind that this is actually a response that our brain has to good or bad, abnormal or outside of the norm events in our lives. And it's very interesting that it sort of does to after a trauma. So it is definitely not considered good or bad or favorable, not favorable, or judgment or no judgment, but rather how our brain is set to respond. And it's very different for everyone.
Wow, beautiful. Thank you very much for this. So how is the management of this? So once again, before we talk about it, for the audience here, this is not an advisory session. There is no medical advice here. There is no patient relationship here. This is more of an educational, informational session. So please, if you need help, talk with your doctors and go from there. Dr. Ashikyan, how is the normal approach to the management? Is this more of a psychological help, or is there psychiatric help, or what else? What are the tools for this?
Excellent. So I want to sort of double down on your suggestion that patients talk to their providers and seek help, because you don't only get to sort of get the treatment that you need for the trauma, but you also get ways to cope with just general anxiety that you experience, general sleep problems that you experience. So it could be a very wonderful experience to get the treatment that you need from a healthcare provider directly. So definitely don't take this as any kind of medical advice or treatment suggestion. But to answer your question, I'm so happy that there are actually various different, very effective treatments for PTSD at our disposal these days. And obviously new methods being recognized and developed very often. In fact, the Veterans Association and the Department of Defense recently came up with written exposure therapy, which is a method of exposure therapy that's even more effective with particularly veterans who might have difficulty verbalizing what would be required in treatment, but are much better at writing. And so again, I'm very excited for that treatment method. It's shown incredible efficacy for treatment, but the treatments are psychological treatment, psychiatric treatment, or a combination of both, which has been found to be most effective, not only in the length of time it takes to reach effectiveness, but also the duration of maintenance treatment. So with some medications, we're talking SSRIs, a few of them are Zoloft or sertraline as it's generally known, Effexor, Paxil, Prozac. These are the most commonly used SSRIs. And then prazosin has been used to treat nightmares associated with PTSD. Now, if you're familiar with prazosin, you might say, that's a blood pressure reducing medication. And yes, not surprisingly, some medications actually do work for various different and rather vastly different illnesses and issues. And so that was an accidental discovery that it does reduce nightmares associated with PTSD. And so those are the psychotropic options for treatment. And psychological treatments, they include EMDR, which is the eye movement desensitization, and then which is sort of built significantly on cognitive behavioral therapy. So I tend to see it as cognitive behavioral therapy, particularly for PTSD, cognitive restructuring therapy, EMDR, prolonged exposure, and so forth, having some aspect or incorporating some aspect of cognitive behavior therapy. And these are the treatments that have been most studied and used. And cognitive behavioral therapy relies heavily on helping the patient become mindful of their cognitions, emotions, behaviors, and their core beliefs. And again, it goes back to what I said about the meanings we attach to traumas, having a significant impact on how we go on to heal from a trauma. And so the cognitive behavioral therapy being one that I significantly rely on, as well as prolonged exposure or in vivo exposure. For example, during COVID, we haven't been able to be in the same room with some of our patients. And so it's been very difficult to actually accompany them to any kind of a prolonged exposure experiment or treatment. So it has been in vivo, which is to imagine. So imagining and doing so slowly. So if someone, for example, was in a plane crash, survived a plane crash, they might not necessarily take on a flight right away, but they might sort of imagine driving to an airport, then sort of going through security and so forth. So these are great tools that clinicians these days use to treat PTSD. And again, the treatments are very effective. They're very helpful. And as I mentioned earlier, the sooner they're applied after the trauma, the more beneficial the treatments are. And again, we're talking for adults only. I only treat adults with any condition, but for PTSD, treatments for children vastly differ for obvious reasons than those for adults.
Got it. Thank you. Thank you very much. Do you have a few more minutes? I know it is 42 minutes.
I do. Oh, wow. Okay. Yes.
For some questions as well.
Absolutely.
Cool. So a quick guidance for the questions. This is a sensitive topic. All topics are sensitive topic. This is especially sensitive. So please make sure that you don't put yourself in trouble, don't put us in trouble by asking personal advice type requests. We can't answer them. We should not answer them as well. So please, if you have a general question around this topic, that will be great for us to talk about. Dr. Ashikyan, give me 1 second. I want to quickly open up the, why not I start from here and I'll open Twitter while you're answering some other question. So let's start. Cindy Glasgow says, hi, Dr. Ashikyan. Do you use QEEG and neurofeedback for PTSD?
So not the QEEG, but yes, we use neurofeedback and biofeedback treatments as well for PTSD. And again, it sort of goes hand in hand with cognitive behavioral therapy. I usually don't do or recommend neurofeedback or biofeedback alone as a treatment method. I think it is very helpful in conjunction with cognitive behavioral therapy to help the patients, especially those who are not necessarily very insightful or very mindful to become very aware of their responses and be able to self-monitor. So yes, great question.
Got it. Thank you very much. On Twitter, there's a question, L. Bowman, and please feel free to pass on a question if you like. What is your opinion of using MDMA, ketamine, high-dose marijuana, or psilocybin assisted therapy for PTSD? Can you recommend a great clinic in the USA?
So great question, given the fact that these substances are currently gaining a lot more momentum for research. So, and that's currently where I'm comfortable leaving them. As far as my familiarity with them is very minimal because they're still not accepted, approved, effective, evidence-based treatments. So I'm always very excited about new methods, new and safe methods of treatment. Those have not yet been approved for treatment for PTSD.
Got it. One more question. Jean M. Oliveira. Question, pandemic PTSD, anxiety, depression. Please discuss cognitive, behavioral, spiritual, pharmaceutical, nutraceutical coping strategies.
Yes.
So whatever you can enlighten us with.
Yes. Could you repeat the beginning part?
Yeah, so this pandemic and the PTSD and the anxiety and depression in it. So how do we cope with this situation?
I see. So as a way to sort of prevent those things, I'm assuming. So yes, absolutely. As with any stressor, you want to make sure that you are well taken care of yourself. This is very different for all of us. For some of us, it is picking up a good book every day. For others, it's exercise. And even exercise method might be different. For some people, it is helpful to do yoga. For others, it is to go into a kickboxing class. And all of those are fine and accepted and great methods to cope if they work for us, right? So making sure that you have good social support. There was a significant sort of movement to make sure that we weren't using actually the word social distancing, but rather physical distancing, so that people knew that it was perfectly fine to seek social support and relationships in other ways. And thankfully, our technology provided that. So eating very healthy, being very aware of the meanings that we attach to things. This is probably the best way to fend off anxiety and depression. Now, I'm going to say something that we psychologists like to think we came up with, right? So cognitive behavioral therapy significantly relies on the idea that our feelings are generated by our thoughts, right? Our cognitions, and these are the meanings we attach to things, right? And so the big movement of like, no one can make you feel a certain way or nothing can make you feel a certain way is an absolutely accurate statement, right? Because our feelings come straight from our thoughts. And so you must have a thought or attach a meaning to what someone says in order for you to actually experience a good or a bad reaction to what someone says. Now, if any of you have read Shakespeare, in Hamlet, Shakespeare says, nothing is either good or bad, but thinking makes it so. So clearly, I don't know how much credit we can take for this discovery, because obviously Shakespeare knew this in the 1600s, right? So, and I absolutely love that very simple statement. Nothing is good or bad, but thinking makes it so. Which also means we have control over whether or not we think something is good or bad, because it is us who will assign the meaning to it. So I want to encourage you to find ways to alter the meanings that you're attaching to certain events. Obviously, those that could possibly be altered, there are certain things universally that are just horrible or just bad or good or whatever. But for the most part, we assign the meanings to the events in our lives, and we hence have responses to them. So that would be a brief sort of how to build resilience during such a difficult time that we've been going through.
Got it. Very, very interesting. I'm recalling I watched a video. Simon Sinek is a motivation speaker or a good guide, and he was saying in one of his videos exactly a similar thing, that the Olympic athletes or military or army related Marines, when they sense fear, instead of saying I'm afraid, for example, from competition in the Olympics or so, they say I am excited about it. This is excitement that is inside me, that the fear or that state of their being at that time. And he said that changes their approach to how do they perceive it and how do they manage it. So one more question. This is a question on Twitter. F. Yusufzai says, what is the differential diagnosis if a patient hears voices after a trauma versus psychoaffective explanations?
Psychoaffective explanation?
Yeah. Let me share the question. Let's see if I can actually make it a little tiny bit larger as well. So what is the differential diagnosis of a patient if a patient hears voices after trauma compared to psychoaffective explanation?
So obviously, we would definitely want to rule out any pre-existing issues. So we want to make sure that the individual didn't already have pre-existing schizophrenia, pre-existing psychotic disorder, or psychosis. Then we would definitely want to make sure that the injury did not also include a head trauma. And so we're dealing with possible post-concussive or post-head injury symptoms. So the causes of it could be vast. So you want to make sure that you're going through sort of like the most dangerous and unmanaged issues. There could be reactions to medications. If the individual is possibly self-medicating by taking medications or mixing medications or taking medications not prescribed to them, or using alcohol or drugs to possibly sleep. This could be a very benign attempt, even not so much sort of intentional use of substances. But of course, you also want to rule all of those out. And then if there are no others, it could be that there is brief psychosis, because of course, brief psychosis can develop after significant crises or a significant stressor. And so you would just go down on the list of various different sort of assessments to make sure that you're ruling out all the possible sort of outcomes. And I'm certain that at the end you would be left with the actual issue that the patient is experiencing.
Got it. Thank you very much. I'm going to answer a question that is probably directed at me. Moorhouse Joplin says, what is MBBS? So Moorhouse, that is the medical doctor's degrees abbreviation from Pakistan, India. I think it is in the UK as well. This is Britain and their Commonwealth countries. When we become physicians there, the degree's name is MBBS. So continuing with the questions, Augie says, in general, is there a particular method best at treating PTSD?
So remember how I said we are so different, that we experience different sort of things at different times. Something very distressing for one person may not be very distressing for another. Treatment is sometimes like that as well. So even with the medications, there's sometimes trial and error. So we decide on the best method of treatment sometimes based on what we've come to learn about the patients. and then of course trying various different methods. But generally speaking, it's sort of some people come in these days saying, I want EMDR, that I've read about it and that's what I want. And so you want to make sure that if you don't provide that, or you're not an expert in that kind of treatment, that you refer the patient out to someone who is. If they come in and they say, I want cognitive behavioral therapy, or they just have no idea about any of the treatment methods, then a good clinician with informed consent would sort of explain the various different treatment methods and what they believe would be most helpful, and then enlist the patient as a very active participant in treatment. I always say that the psychological treatment is very different than all other sort of medical treatments, where treatment is applied onto the patient, as opposed to psychological treatment where the patient should become a very active participant in the treatment.
Got it. Thank you very much. Rubies are red. Can you ask whether NLP is being used for PTSD in her clinic? I'm assuming your clinic or your practice.
Yeah, I'm going to need to know what that abbreviation stands for. It might be something we're using, but I'm not sure what the abbreviation stands for.
Got it. So Ruby, can you please give us a little more context there? More question. So M. Gregory says, I love this lecture and doctor, a change of pace. So these are all our own cool beans. So good comments from there. Let me get to the next question. I have a question as well, but let me, my question is that when we say that the perception or us assigning meanings, I personally sometimes am at a rational level aware that I'm bothered by this thing and I can think positive. And I still sometimes am not able to switch to that. And I just keep protesting in my head for some time. Is that a normal and natural thing?
Okay, so I'm going to pretend you didn't say I.
Yes. So not for me. Hypothetically.
I'm kidding. We stress the importance of not treating this as personal medical advice.
Yes.
So I'm going to say this.
My apologies, scratch that.
Well, I actually have a problem with the term positive thinking, and I'll explain why. Okay, so negative thinking and positive thinking. Positive has such a positive connotation to it, right? People assume that's a good thing. But to me, positive thinking is just as skewed as negative thinking, right? So I have a problem with both thinking. And so I don't want anyone wearing pink sunglasses to view the world and interpret information in their world. I don't want someone wearing dark, gray, gloomy sunglasses either. I want us to strive to view things from a realistic perspective. When people say, I'm going to fail a test, and someone says, oh, you're thinking negatively, think positively. The opposite end is, I'm going to ace that test, right? Well, I'm going to come in and say, you do not know. So what you're going to say is, I've studied for the test quite a bit. I've reviewed all the material. I am as prepared as I possibly can be. I will do my very best. And I know that when I've done that in the past, it has resulted in a good grade. Does that make sense? It's not as glamorous as positive thinking, but I do have a problem with positive thinking because it is as skewed and as much of a guesswork, right? And fortune telling, as we call it, and obviously a distortion. Unless any one of us think they're fortune tellers, we should be doing neither, right? We should be sort of in the middle. We don't know what the future holds for us, but what we do know is what we've done to prepare for that future. So I hope that answers your
Excellent.
question.
Absolutely, absolutely. Thank you very much. Morehouse Joplin says, do you recommend starting treatment for ICU staff currently dealing with the surge?
Oh, excellent point. So I have been asked to speak to several different hospital physician groups in providing information and education regarding burnout. So I'm not sure if that's sort of what you're talking about, or the trauma, the immense trauma of the responders in the hospitals, treating patients, losing some patients. So I've done those talks with great pleasure. I have not said no to any of them that I've requested it, because I think it is so important that physicians are reminded, clinicians, not just physicians, clinicians of all specialties are reminded that self-care is not selfishness. It's a must, especially during these times. So I don't recommend it for that particular ICU. I recommend it for everyone. Everyone who is treating patients should take an hour during their day to make sure that they're reminded of all the benefits of self-care.
Got it. Thank you very much. M. Gregory says, any non-drug alternatives to PTSD? I'm assuming management.
Yes, so we talked about psychological treatment and the inclusion under that umbrella of psychological treatment, as in talk therapy, right? So those are things. Obviously, I mentioned all the things that I can provide, but clearly doing meditation is very helpful for some individuals, as well as physical exercise, hiking, getting in touch with loved ones. There are some people who find that difficult after having experienced trauma, because family or friends want to talk about the trauma. And I encourage people not to avoid family and friends in a way to avoid talking about the trauma, but to make a deal with their family and friends that we want to hang out, let's see each other, or let's talk on the phone, but no mentioning of the trauma, or no talking about that. So if that's what you're struggling with, because a lot of people will say, like, I'm isolating, I'm avoiding my loved ones, and because I don't want to talk about, I don't want them to bring it up, I don't want to talk to them about it. Don't avoid them. Make a deal to see them and talk to them, and not talk about the incident or event.
That is so beautiful. Thank you very much. And it actually almost starts answers the next question. So Sean says, what about training and including family in treatment?
Great question. Absolutely. So yes, and a special attention to the little members of the family, because they're not always so obliviously unaware of what's going on. They may not know all the details, but they see the changes. So you always also want to be aware. As I mentioned, I don't see any children, but so many incredible clinicians do. So I always say that if the family also needs some help, and sometimes the family needs some psychoeducation, they just need to sort of know what is going on. They need to know what the individual is going through. They want to understand them, and they want to know what they can do. And so that sometimes is all that is needed, some brief psychoeducation. In other times, family therapy is helpful, either together or individually. Everyone is in therapy individually. So whatever each family finds helpful is what is advisable that they follow. Not so much a prescription that this is how it should be for all families across the board. And obviously one needs to be aware of cultural differences. In some families, it is not so acceptable to talk about feelings or difficulties. So you clinicians always want to make sure that you're aware of those sensitive issues and take those into consideration when dealing with patients who have PTSD.
Got it. Thank you very much. So one more question. I know it is more than an hour now. This is an important question. So Caroline and Raj's mom, so she has a Bengal. Does Dr. A believe there are any validity to EFT, emotional freedom technique, tapping, in addition to psych treatment for PTSD, anxiety triggers, etc.?
So I'm not familiar with emotional freedom technique and tapping. It does sound like EMDR because EMDR can include tapping as well. So I would assume that any treatment method that you're seeking, if it is, so I'm aware that in the United States it is not, that treatment methodology is not an approved or evidence-based treatment method. That doesn't mean that it's not worth trying and so forth. So you want to make sure that you obtain the treatment from someone who is certified, trained, and has actual sort of a school certificate or some training program that is accredited and approved in the United States or wherever you're seeking the treatment, that has been found to be helpful. And so that you can make sure that the time and possibly the money investment that you're making to the treatment is actually helpful and effective. And it's very easy to tell also if, for example, if you stop having nightmares, or if there are measurable sort of ways to assess whether treatment is helpful.
Got it. Thank you very much. And I promise that was the last question, but there is another beautiful question here. So if you don't mind.
Of course, I'm okay with time.
Thank you. So Augie says, any breakthroughs on memory protein research to block or relieve such memory triggers?
Indeed, a great question. And significant research did go into that. And there were some medications that were possibly being considered as a way to sort of block memories related to PTSD and so forth. And unfortunately, because these memories are not generally sort of kept in this one particular area, as anyone knows with memory, these are really just neurotransmitter and synaptic sort of ways our memories are stored. So it's very difficult to completely disintegrate some memories or connections without possibly be doing damage to others. And I think obviously we can all hope that there will be a way to do that, possibly, but unfortunately at this time, none of that research has actually resulted in any measurable sort of approved method of treatment.
Got it.
For that reason.
One more question.
Please, I'm okay.
Thank you. So Bambi Secret says, how can the general public support healthcare workers, their family, doctors, hospital doctors, GPs to ensure they don't have PTSD from working through the pandemic? I worry about NHS staff in the UK.
That is such a lovely heart. Whoever that question is coming from, yes, beautiful heart from Bambi Secret. Hi, girl. I remember you from our Zoom calls. Yes. So, beautiful question. It's one of those things. So when a patient comes in, I don't know if I remember if I mentioned this or not, but when someone says, you know, I'm having all these images of these difficult incident or event that I experienced. I keep thinking about it. I get flashbacks of it. I'm so distressed about it, and so on and so forth. My response is, I think I would be worried about you if you weren't impacted by it. And in this case too, I think what our clinicians, our hospitalists have seen, have lived through, I think it would be surprising and worrisome if they weren't impacted by it. So I'm certain that at various degrees, they have been impacted by all the negative, all the suffering, the pain. Even when patients improve, they're leaving with significant health issues sometimes, especially if they've been hospitalized and so forth. So I definitely think having an awareness, right? That's where it starts. Just being aware that this is what they've been dealing with. Being a lot more appreciative where we can. And if you're able to, reaching out to these hospitals, and I know that Glendale Memorial Hospital, where I'm a board member for the foundation, received tremendous support from the community. Whether it was food being brought to the hospital, whether it was donations of monetary or material needs, initially masks. And so that's always very, very wonderful, and obviously shows a great appreciation. But also in the treatment of our healthcare providers. In any way we can, if you become aware that someone is a healthcare provider, and you're speaking to them, you're not bothering them in any way, saying thank you for everything that they've been doing over the last year and a half, finding out if there are ways to help. And so, great question. And yes, that is one thing that we can definitely do for them, is be aware of it and try to help if possible.
Got it. One related question from Cindy. How would COVID work-related PTSD affect a medical provider's ability to take care of patients? Or can it affect?
It could, right? We're all human. It could definitely impact it, just like I mentioned earlier, first responders responding to numerous calls, sometimes in one day, that are very distressing. So it's very, very possible. I'm not sure about patient care. Thankfully, at hospitals, most individuals are treating in teams, so these issues are a lot more sort of easily recognizable, identifiable. And again, the goal is to make sure that the physicians and other specialties are aware that this is a difficult situation, difficult time, and it's normal to experience these symptoms. And of course, to be able to respond appropriately to them. So maybe to seek time off, maybe to seek some treatment and so forth. But can it become problematic? Yes, absolutely. Just like if you experience a car accident, do you drive with a lot more anxiety the next day? Are you a lot more cautious? It's almost like you're aware that an accident can happen, as if that wasn't the case yesterday too. An incident or event can definitely make us a lot more aware and affect us as well. So can they be affected? Yes. Can it get into patient care and so forth? The hope is no, but does it happen? Of course, which is why there are many different steps that, as I mentioned, hospitals are taking to ensure that their healthcare providers are staying healthy, and not just physically, but emotionally as well through this time.
Got it. So with this, thank you very much for your time, for your insights, and for discussing this topic, which is definitely out of my league. So thank you for coming on the show and for your time.
Thank you so much for having me. Such a pleasure again. Thank you.
Thank you very much. And Cool Beans, thank you very much. So we will see you tomorrow, and we're going to hang up for now. Bye-bye.
Bye-bye.